No, I really loved your presentation today. I thought it was very applicable to all of us in the room. I think a lot of patients also need to hear that as well. Not from the discussion that you have, I think, with patients, but just for them to kind of consider their own pain. And you talked at the very beginning about the three kind of pain models. The one of them being the main one that we use, which is the biopsychosocial model. I wanted to get your opinion, and as you've become an expert in pain, and made that very clear today, how you use the biopsychosocial model and kind of compare that with the other models of pain, and maybe how you actually apply that in your practice.
So the biopsychosocial model really is, there's sometimes a biomechanical cause and there's a tissue pathology cause, but we have to entertain the thought that pain drivers and our perceptions of pain and also how we deal with pain has a lot more to do with just biomechanically how we're moving. Sometimes, as in the orthopedic side, we just oh, well, you're not moving appropriately, so it has to be this. When it could just be maybe there's a fear of movement that's falling into that category, and then that becomes our just not only social but psychological aspects when it comes to that. And it's unfortunate because we use the word psychological, and people color that a little differently, when psychological really is just our perception of what our brain, the master controller, is really telling our body based on our experiences, our past experiences, what we believe, how we want to act. The fact that I've been looking in the thorn bush for those palm fronds, and so what we believe is going to happen oftentimes will. And so there's another old saying, sometimes whether you believe it is or it isn't, you're probably right. And what you believe about your injury oftentimes is right. If you believe that it's going to be debilitating and that it's going to be the worst thing ever in your life, and that that your career is over, then sometimes it will be, unless you're willing to consider and change your mindset on that.
And you briefly touched upon that with the story of the snake bite, where that doctor's reaction based off of the first snake bite versus when later on his leg got touched by a twig, he reacted very differently because of that. How do you use that model as you're counseling patients? For example, let's say they've just had a total knee. That's obviously relative to me.
Right.
And they've heard, like you had said, their friend had it, and so it was the worst experience in the world, versus their friend had it and they had no pain. And here they are somewhere in that spectrum. How do you kind of communicate that with them and really counsel them in a way that you try to affect their pain psychologically? Obviously, you can affect their pain physically as you help them with therapy, but how do you try to counsel them in those situations?
So I think it's probably a two-part question, which I agree in, and I think as practitioners, we're much better at it than we used to be. Now we just tell people, it's variable. Some people feel more discomfort than others, and normally you should be able to getting back to that. And the question really, people will say, okay, how long do you expect this to take? And so that's the first sort of them just edging into this, I've heard other things, but you're the expert, at least the one right in front of me right now, because Google's the other expert. How long is it supposed to take? And I think that it's important, the language and what we use when we say, generally speaking, these go very well. You had a great surgery, you've had no complications. I have no reason to expect that you won't fall into the category of doing amazingly well. And for me, the second part of that is I don't want to use ambivalent, but then again, I don't talk a lot about pain. I'm it looks great. I think you're going to do amazing, because I expect all of my patients to do amazing. And if I can translate that confidence and how well they should do based on what I see, sometimes that just moves over to them, and they're my doc thinks I'm going to do amazing. And you had a great doctor. So I think that the part, at least when it comes down to the physical therapy world, it's you had no complications, everything's going well, you're bending great, you had great home health, you're in PT. I see no reason why we can't continue. And if there's any concerns, I'll be the first one to tell you if I have a concern. But if I'm not saying anything, let's just keep going.
And that's very similar to the very ending when you talked about that functional MRI. That is those patients that are having that post, or that's having the pain education.
Yeah.
Their functional MRI was, completely night and day different. When as you in that study specifically, what was their pain education that they were provided that led to that drastic difference between their pre-MRI pain and their post-MRI lack of pain on the MRI?
Yeah, so that education is a lot longer. It's like a 2.5-hour session, but it's very similar to helping them understand the alarm state, the resting state of our nervous system, how pain is really a sensation from nociceptors that are injuring the tissue that comes up to the spinal cord and goes to the brain, and then the brain makes a decision based on that whether or not we can keep going. And whether the brain decides to override that, sometimes helpful, sometimes not, explains why some people can have like a grievous injury and still lift the car off their children, or walk around on a broken ankle. Like, we've seen those things. You're like, how does that happen? But it's the importance of if the brain decides that this is something that it can deal with later or doesn't have time to deal with now given other situations, then it will override that. It will override that pain, and helping patients understand that they can modulate that pain by just telling themselves, like, I've got this. I think this is something that is going to be okay, right? If we can instill that belief in them. And so that pain education is a lot like when we talk about that elevated alarm state where their brain is now focusing on their knee and their pain, and every time they bend it, they feel the incision move, and they're like, oh, this must be bad. And if we can get them out of that alarm state by just the pain education, what it does is it sort of reduces that resting level of just anxiety, was what we would call it, but just that resting level of attention and
sensitivity, as you talk about.
Activity state for the neurons to want to fire. If we can reduce that, then they can move through it without sending alarm messages to their whole body.
I like that. As you talked about a little bit ago, the setting the expectation of the patients. I think that you said they come in and you say, look like everything went well, you're going to do awesome, before you even ask them how they're doing or you even evaluate them. I think that's a great recommendation for all of us. So I think therapists are put in a very difficult position as you're between the patient and their surgeon or their physician or their intervention specialist, right? I think with that, it's very difficult because here you are trying to make them better, but you're also trying to be the front lines kind of evaluator for their surgeon or their interventionalist as to how they're doing. And I love the communication we have with our group. I know with you, you'll frequently text me and say, hey, here's how this patient's doing. I have a concern with this, and we address it. As you're dealing with both sides of that and you're kind of in the middle dealing with pain, how do you work out dealing with pain and not trying to just make a patient better and say, okay, this is all in your head, you got to do better, but you're also recognizing that there are certain things that you've got to be aware of and let the surgeon know, and kind of, how do you mitigate that? Because I think it's a difficult spot to be in. Yeah,
and it's funny because I actually had a patient who had a lot of complications preoperative, and they still did surgery, and had a lot of postoperative pain for just unknown reasons. Like, he was a young kid, not predisposed to any of those types of things, but just was not able to manage his pain, and just communicated that to the surgeon. I'm like, his pain's actually not managed well. And the surgeon got back to me and just like, he's not used to hearing that from me. So, and I think that's what it is. Like, if I told you somebody was in a lot of pain and they weren't doing well, you'd probably raise your eyebrows as well, because it's not something that we usually see. And so I think the importance is recognize it and manage it for what it is. Mm-hmm. Like, some people are going to have that situation. It's going to happen. And whether that's just a lot of tissue damage or they've talked themselves, I say they talked themselves into it, but they didn't. Their brain has told them that this is what's happening, and they've not managed to be able to sort of shut that down. So then it's more than appropriate to get pain management on board so that we can continue to function and also have the continued conversations about what opioids can do, and how long we should be on them. And then if we move somebody in that pain conversation, that's probably not where you wanted to go, but if we move somebody in that pain conversation and they have to start taking more medication, then I am constantly on them on the backside, asking them when they're tapering and when they're done. Like, because I don't want to see that get to something else. And as we talked about before, like, opioids block those pain receptors, but your body's great. If your brain decides it's time to pay attention to pain, it'll just add more receptors. And you can add more opioids.
Yes, and we've seen that, right? There's patients who've been on chronic pain for years and years and years, and they actually get off of it and their pain goes down. And I think it's interesting that that it's more than just the bio model. It's not bio, it's biopsycho and biosocial,
Yeah.
where everything kind of pulls together to it. So if you were to kind of give the final recommendation to providers who think about pain, and if you were to grab every surgeon that has frustrated you in the world with their patients and how they counsel with pain, what would you tell them they need to do better to counsel their patients with pain in a preoperative state, so that when they come to you, your job's not as difficult?
I love the aspect of downplaying how I love the aspect of sort of downplaying how difficult the recovery and the surgery can be, because I think that our belief in, again, if we believe it's going to be bad, then it's going to be bad. Like, oh, this is a big surgery, I think that it's like, it's going to be a little bit rough, but you're going to get through it. I see people on the other side, and I think it's more important for us to paint a picture of what the recovery side looks like than the immediate post-op. Like, it's going to be a little rugged, but I'm just telling you, like, the goal that we're looking for is over here, and if we can keep our eye on that and just know that we're gonna be in the suck for a little bit, which is fine. People know that. I think most people inherently know that when they're having a surgical procedure, that it's going to be difficult for a little while. I don't think that's a surprise to them. So I think sometimes we hide from it. We do the surgery, and you're like, oh yeah, you're in pain, and then we boot because we don't want to deal with them. We're just like, no, you're going to be uncomfortable for a while, but you knew this going in, right? And there's a goal on the other side. And nowadays we don't do surgery unless we really feel like we can make a measurable difference. Right. And that frustrates some patients because they got a doctor who's like, I just don't think I can fix you. And they're like, he said he couldn't fix me. Maybe there's a lot of other things that are happening
that are involved. Yeah, I think one of the things I using that idea as I try to counsel my patients is, when it is time for surgery, I really like them to have a mental checkbox that, hey, here's your pain. You've had, let's, for example, knee arthritis. You've had knee arthritis. You've done this. Nothing's worked to this point. You've kind of checked every box. That's important before we decide on surgery, because on day one, when you wake up and you do have pain, you kind of do a mental checklist and go, this is where I have to be because I've gone through it. And I feel like as a result, patients can manage that better rather than the, oh no, this hurts. Oh no, I shouldn't have done this.
Yeah.
Because they haven't gone through that kind of pre checklist.
I love that. I mean, because it should be the last option. It's always frustrating when people pick it as their first option.
Yep.
Yeah.
Awesome.